Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. Today we're going to be tackling a pretty sensitive topic, one that we as surgeons don't encounter every day, but is absolutely crucial to be prepared for.
Yeah, absolutely. And, it always kind of throws a wrench in the works when it does come up.
Definitely throws a wrench in the works.
Yeah,
We're talking about breast cancer during pregnancy. It's a tough situation, and we need to be ready to make the best decisions for both the mother and the baby.
no doubt about it. And just to clarify, we're going to be focusing specifically on the surgical perspective here, what we need to consider when operating on a pregnant patient with breast cancer.
Right, exactly. So let's dive in. First off, one thing that always strikes me is that breast cancer diagnosed during pregnancy just seems to behave differently, often more aggressively.
Yeah, that's a great point. We often see a higher proportion of triple-negative breast cancer, which, as we know, is more aggressive and harder to treat.
Exactly, and that really impacts our whole approach. So let's talk about diagnostics. Imaging is obviously crucial, but we have to be so careful with the fetus involved.
Absolutely. Ultrasonography of the breast is always our first step. It's safe, it's effective, and it can give us a lot of information.
And mammograms, we can still use those, right?
Yeah, mammograms are still part of the workup, but we're super meticulous about shielding the abdomen to protect the baby. Same goes for chest x-rays. We always use abdominal shielding there as well.
Makes sense. Now, what about those cases where we need more detail? Like if we suspect metastasis, what's our next move?
Well, MRI can be really helpful in those situations. It gives us a really clear picture of what's going on. But there's a catch.
I bet it's the contrast.
You got it.
Yeah.
We can't use gadolinium contrast during pregnancy because of the potential risks to the fetus. So we reserve MRI for cases where we strongly suspect bone or brain metastasis, or when other imaging just isn't giving us a clear answer.
Okay, that makes sense. And I'm assuming CT and PT-CT scans are off the table completely.
Absolutely. The radiation exposure is just too high, too risky for the developing baby. We avoid those completely during pregnancy.
Good to know. Now, given the complexities and the potential for hereditary factors, I imagine genetic counseling is a big part of the picture here.
Huge. We offer genetic counseling to all pregnant patients diagnosed with breast cancer. It helps us make informed treatment decisions, understand potential risks for the mother in the future, and it can be really empowering for the patient to have all that information.
Absolutely. So let's talk surgery. I know this is where your expertise really shines. Can we safely perform surgery on a pregnant patient with breast cancer? And if so, at what stage?
The good news is that yes, surgery can be safely performed during any trimester of pregnancy. The key is close collaboration with the anesthesiologist and the obstetrician. We need to make sure the anesthesia is carefully managed and that the fetus is continuously monitored throughout the procedure.
That's reassuring to hear. And what about the type of surgery? Do we lean towards lumpectomy or mastectomy in these cases, especially during the early stages of pregnancy?
We often prefer mastectomy, particularly in the first and second trimesters. The main reason for that is to avoid delaying postoperative radiation therapy.
Ah, I see. Because we can't do radiation during pregnancy.
Right. And delaying radiation could increase the risk of the cancer coming back. So mastectomy allows us to move forward with adjuvant treatment without waiting until after the baby is born.
Makes sense. What about axillary staging? Is sentinel lymph node biopsy still the standard of care?
It is. And we can do it safely during pregnancy using low-dose technetium-tagged sulfur colloid. This method minimizes radiation exposure to the fetus.
Okay, good to know. So we've talked about surgery, but what about systemic therapy? Chemotherapy is a bit trickier, right? Especially in the first trimester.
Absolutely. Chemotherapy is completely contraindicated during the first trimester. Those first 3 months are critical for organ development in the fetus, and chemotherapy can have serious teratogenic effects. We can't take that risk.
But I imagine it's an option later in the pregnancy.
It can be, yeah. We can generally administer chemotherapy relatively safely in the second and third trimesters, but again, there are limitations. We usually stop chemotherapy around 34 weeks gestation to give the mother's bone marrow time to recover before delivery.
That makes sense. And are there any specific chemo agents we prefer or avoid in these situations?
Anthracyclines and taxanes are usually our go-to agents, but we absolutely avoid 5-fluorouracil during pregnancy. It's just too risky for the baby.
Got it. And finally, what about targeted therapies like anti-HER2 agents and endocrine therapies? Where do those fit in?
Those are usually reserved for after the baby is born. The potential risks to the fetus during pregnancy outweigh any potential benefits.
So we've covered a lot of ground here, from the unique characteristics of breast cancer during pregnancy to the diagnostic challenges and the surgical and systemic treatment considerations.
Yeah, it's a lot to think about, and it really highlights the importance of a multidisciplinary approach. We need to work closely with the oncologist, the obstetrician, the anesthesiologist, the radiologist, and of course the patient herself to make the best decisions for both the mother and the baby.
Absolutely. It's a true team effort.
Couldn't agree more.
Well, thank you for listening to our deep dive today. We'll see you next time.
See you then.
Bye.